rather than rapid-acting insulin analog. But if you have somebody doesn't eat snacks, the opposite. Better to give rapid-acting rather than short-acting. So it depends on the number of meals, number of snacks to choose short or rapid. And for the basal, you have either intermediate, you have glargine, you have ultra-retard as a basal insulin. Also depends on the lifestyle of the patient, on the exercise. Does he have in between meals exercise, or this patient is always sitting, not having exercise? So according to the lifestyle of the patient, the doctor will choose 2 types of these insulin. Regarding the number of injections, as we mentioned, those on 2 injections per day called conventional, those on multiple injection 3, 4, 5 called intensive therapy, and also the best thing for diabetic is insulin pump therapy. The target blood glucose readings for diabetic before meal should have between 80 to 120, 2 hours postprandial up to 180. This is diabetic, not normal person. And at bedtime, the sugar should be between 100 and 240. And the hemoglobin A1C for children is different than adult. The young children, we can accept up to 8, but most of our children, we should have them below 7%. This trial is very important trial. I want you to understand. This trial called DCCT. DCCT. D from diabetes, C control, the second C complication trial. This study showed us whenever we have a good control, we have less complication. If we have poor control, we have more complication. What they did, they get this trial done in America, in Europe, in UK. They collected over 100,000 of patients on insulin. They make them in 2 groups. One group taking only 2 injections per day. The other group taking 3, 4, 5, multiple injections. They follow these patients for at least 10 years. They follow what? They follow their growth parameters, their blood sugar, their hemoglobin A1C, their complications throughout the trial period. The trial period was over 10 years. What they found? They found that those on multiple daily injection, they have a lower hemoglobin A1C and they have a better control and less complication. So with multiple injections, good control, less complications. With only 2 injections per day, they have a poor control and high complications. And what are the complications they looked for? They looked for first stage of nephropathy, which is microalbuminuria. They looked for neuropathy, nephropathy, retinopathy. And as you can see, if you have a hemoglobin A1C 6%, this diabetic, the risk of complication is what? Is almost 0. And whenever the hemoglobin A1C increase, the risk of complication is increasing. And this is the message we are telling our patient diabetes, that not because you are diabetic, you will have retinopathy, you will have nephropathy. No, it depends on your control. If you have a good control, less complication, bismillah. If you have poor control, more complications. So the message is not every child, not every adult with diabetes will have complications. It depends on the control. And the control depends on what? And ba'd fadlullah, it depends on the hemoglobin A1C. And the hemoglobin A1C, ba'd fadlullah, depends on what? On the number of the injections. More number, better hemoglobin A1C, less complication. And those two, with 2 injections per day, they have one in the morning short acting and 1 intermediate. In the evening, 1 short acting, 1 intermediate. In between lunch, they don't have any injection. That's why in between 2 injections, their hemoglobin A1C or their sugar is high. Those on multiple injection with every food should have either short or rapid acting insulin. That's why they have better control. Multiple injection, they have better control. And there is basal bolus therapy. We give 1 injection of, for example, glargine as a basal insulin, and with every meal there is a shot one of your friends asked me about this slide, and this is the best regimen. With every meal, should have injection, and one injection as a long-acting glargine, basal insulin. This is the best regimen we have so far, and the insulin pump is another best regimen to give our patients diabetes, whether children or adult, either insulin pump therapy or basal bolus therapy. And this is my first child to have pump, 2004, at the year of 2004, and about 11 years ago. Now she's, I think, in the university. And this is the first was used in the past, and now the recent pump is like Pager-like size, where there is a computer program inside it. The doctor programs the doses, the insulin inside this pump, and from the insulin there is a butterfly coming out, tube with butterfly to be inserted under the skin. Yeah. Yeah. No. Yani we divide the insulin, for example, in 4 doses. Also, we divide the percentage of the basal to the bolus. For example, 60% of total daily dose as short, 40% as a basal, or 70-30. The ratio will be different from one person to another according to the activity, to the body weight, pubertal age. But at the end, we should make, for example, percentage for short-acting, percentage for long-acting. Yes, yes. No. He's asking when the hemoglobin A1C is good, shall we go back to 2 injections? No, this is lifelong. Because hemoglobin A1C is changing every 3 months. So if this 3 months is good, but then you change them 2 injections, next 3 months bad. But this is not, this lifelong disease. Every time you test hemoglobin A1C, it should be normal, every time. No. So insulin pump therapy is just very important technology. We'll not go through it, but when you come in my clinic, you will see practical insulin pump, but it is the best, I think, available nowadays. Also, in June 30, 2014, about 6 months ago, or 8 months ago, there was a new inhaled insulin as a bolus, as a short-acting insulin. So those who are having basal bolus, he will take only 1 injection of long-acting insulin, and for every meal he should have puff or 2 from this inhaled insulin. So far, so good. We don't have any side effect from this medicine, but just it's 8 months ago. We'll see how it go on. It's not approved for children. It's only for adult. Islet cell transplantation and stem cell transplantation is a final cure for diabetes. So far, it's not successful. So far in diabetes, whether in Saudi Arabia or in America, stem cell and the islet cell, they are not yet a clinical cure, still in trials, but maybe one day we'll have this therapy approved for diabetes, which is a cure. And Harvard in America, in November, they said they have managed to treat rats with type 1 diabetes with stem cell, and they said they will start trial for the humans from November 2014, at least for 1 year, 2 years. We are waiting for the results of Harvard University, whether stem cell will be successful to treat humans, but they succeed in rats with type 1 diabetes. So now we are waiting for them to succeed in humans. Complications, diabetes complication, whether type 1, type 2, the same complications. Whether children or adults, the same. But the message, please, the message take home, not the complication, not for anyone with diabetes. Only for those with persistent high hemoglobin A1C. This is the message. Because a lot of diabetic, they think, خلاص, I got diabetes, I will have retinopathy, I will have nephropathy, I will have impotence, I will have like this. No, the message only for those with resistance high hemoglobin A1C, after mashallah they will have complications. What are the complications? Retinopathy, cataract, hypertension, renal failure, coronary heart disease, peripheral neuropathy, and autonomic neuropathy. Associated autoimmune disease, type 1 diabetes, we mentioned that we said autoimmune thyroid disease, we said celiac disease, we said Addison disease. Now a few slides only in type 2 before we finish our lecture. Type 2 diabetes in children and adolescents. I chose to write type 2 diabetes in children and adolescents to emphasize that now it becomes one of the problems in the whole world, not only Saudi Arabia. Type 2 now is appearing in children and adolescents, and the most predisposing factor for that is what? Is junk food. The most important factor to have obesity and then type 2 diabetes is because of junk food, ice creams, fast food, high calorie food that made our children obese. And when our children are obese, they are at risk of type 2 diabetes. And every child, to see whether this child is obese or adolescent or adult, we have to make weight for height, BMI. Do you know how to calculate BMI? Do you know how to calculate? It is the kilogram, the weight, divided by square meter. And also we have to measure skin fold thickness, waist to hip ratio, and there are BMI charts for children to know whether they are overweight or obese. Initially, in type 2 diabetes, there is insulin resistance, i.e., insulin production by pancreas is normal or even high. With time, it is progressive disease. Type 2 is progressive disease. With time, the insulin production will become less, and at that time, the doctor will shift the patient from oral hypoglycemic to insulin therapy, because type 2 has two stages. Stage 1, early the disease, only resistance. Stage 2, resistance and insulin deficiency, where the patient should have insulin therapy for type 2. We have to screen any obese. We have to screen any obese child, adolescent, adult for type 2. The criteria of diagnosis, the patient should be overweight or obese, plus family history of type 2, plus ethnicity of American, Indian, African, Hispanic, sign of insulin resistance, Acanthosis Nigricans, dyslipidemia in the female polycystic ovary syndrome. And this is the classical picture of Acanthosis Nigricans. As you can see, the skin around the neck is dark and thick skin. And usually Acanthosis Nigricans and obesity associated with insulin resistance, hyperinsulinism, arterial hypertension, hyperlipidemia, and polycystic ovary syndrome in the female. The best therapy to prevent and to treat type 2 is exercise and healthy food. So now the question of type 2, is it preventable? We said type 1 not preventable, type 2 yes, it is preventable, and this is also our duty to do a health education about doing exercise, eating healthy food. And I'm not sure you know about this or not. We had a campaign in the last summer holiday about educating people on healthy food, exercise in shopping malls among Jeddah, and inshallah we have this campaign again to be repeated after 1 week or 2 weeks. 20 March, inshallah, we'll have the campaign again. We are going to 8 shopping malls in Jeddah, distributing pamphlet about education, how to prevent obesity and type 2. Any one of you want to join the volunteers, all of you welcome to be part of this health education campaign. Weight exercise, the mainstay of prevention and therapy. In addition, if somebody had diabetes, they might have, in addition to weight loss and exercise, metformin, which is the best therapy for insulin resistance, and insulin is the last modality of therapy, not like type 1. Type 1, number 1 insulin, and type 2, last therapy or last option is insulin therapy. Metformin is the best oral hypoglycemic medication to improve insulin resistance. So type 1 and type 2, although they are common among children and adolescents with diabetes, type 1 is the commonest, type 2 is appearing, but we have to educate our families on the healthy food, on the exercise, in order to prevent type 2. Any question? This is the end of my presentation, my lecture. Any question, please ask. No, we said weight, exercise, then weight, exercise, and metformin, then weight, exercise, metformin, insulin. Any pediatric, adolescent, adult, the same principle. Weight loss, exercise, number 1. If not managed with 6 month intensive exercise, weight loss, we could add metformin. If with metformin, exercise, diet, still the sugar is high, they could add other oral hypoglycemic or insulin. Yes, type 1, please. Type 1, there is no way to give oral hypoglycemic type 1. There is no way to tell them diet, exercise only for type 1. Diet, exercise, and insulin from day 1 of diagnosis. From first day of diagnosis, tell them weight, exercise, weight loss, diet, and insulin. Insulin from first day of life. There is nothing, say, okay, let him do exercise and diet. No, not like diet type 2. Type 1 from first day insulin therapy. That is why